Waking up after a successful atrial fibrillation ablation brings an incredible sense of relief. The erratic, exhausting heart rhythms are finally gone. Suddenly, the everyday milestones that used to be a struggle are entirely manageable. You can walk up a flight of stairs without gasping for air, jog a 5K, and get through the day without crushing chronic fatigue. On land, your cardiologist might look at your charts and clear you to resume a completely normal life. But if you take those exact same charts to a diving medicine physician, they are going to ground you. To understand why, we have to look at the math of returning to the water. This quadrant chart plots dive complexity against medical risk. Before surgery, your erratic rhythms put you in the extreme high-risk quadrant. The procedure drops that baseline risk, but immediately introduces new mechanical uncertainties because your heart was physically altered. Those physical alterations collide with the unique physics of the ocean. The simple act of immersing your body in water forces blood from your extremities into your core, spiking your cardiac preload. Add in cold water, which constricts blood vessels, and your heart must pump against a massive increase in afterload. To fix your arrhythmia in the first place, the electrophysiologist had to pass a catheter into the left side of your heart. To get there, they literally punched a physical hole through your interatrial septum. Down here, unexpected complications aren't met with a crash cart. You are entirely reliant on your own physiology to safely reach the surface. Getting safely back to the reef requires navigating a rigorous set of trade-offs. It requires mapping your physical healing and managing new medications, and proving your heart can handle the crushing physics of the underwater environment. The absolute minimum requirement before you can even think about strapping on a tank is time. Diving medicine physicians mandate a strict waiting period of at least 6 to 12 weeks post-surgery for the cardiac tissue to heal. Once that clock runs out, you have to prove your engine can handle the strain. The strict medical threshold is demonstrating an exercise capacity of 10 to 13 mets without experiencing any symptoms. This decision tree maps out what that actually means on a dive boat. Hitting 10 to 13 mets equates to climbing a pitching boat ladder in full steel gear, or swimming aggressively against a strong ocean current to help a buddy. If your cardiovascular system cannot sustain that level of exertion, the fluid shifts from immersion overwhelm your heart. This triggers immersion pulmonary edema, where your lungs rapidly fill with fluid while you are submerged. Even if your physical stamina is flawless, your medication list might still disqualify you. Post-ablation patients are frequently prescribed anticoagulants to thin their blood or beta blockers to suppress erratic rhythms. On land, full-dose blood thinners are an incredibly effective tool for preventing strokes. On a dive trip, they transform minor bumps and bruises into massive liabilities. A heavy scuba cylinder swinging on a rough boat deck or a simple slip on a wet fiberglass ladder can cause severe, uncontrolled internal bleeding if your blood cannot clot. Beta blockers present a completely different mechanical problem. By design, these drugs artificially cap your maximum heart rate. They excel at keeping your heart rhythm stable, but they throttle your ability to output sudden, explosive energy. If you get caught in a rip current or need to tow an unconscious diver, your artificially capped heart simply will not let you generate the necessary power. The math is unforgiving. Even with a corrected heart rhythm, remaining on heavy doses of these medications or failing to rebuild your physical stamina makes the underwater environment unacceptably dangerous. We now have to address the heart's anatomy, specifically the transseptal puncture created during the procedure. Most of the time, this hole seals up on its own. However, up to 15% of patients still have a patent hole, an iatrogenic atrial septal defect, or iASD, a full 12 months after the operation. This cross-section of the heart shows normal underwater physiology. Venous blood returns from your body into the right atrium, moves down to the right ventricle, and gets pumped safely to the lungs. As you ascend from a dive, microscopic nitrogen bubbles naturally form in this venous blood. Normally, they flow out of the right ventricle and are safely trapped and filtered out by the capillary beds in your lungs. An unhealed iASD creates a gap in the central wall separating the right and left sides of the heart, acting exactly like a patent foramen ovale, or PFO. Under the stress of diving, clearing your ears with a Valsalva maneuver, coughing, or heaving a tank causes a sudden spike in right atrial pressure. This forces the nitrogen bubbles horizontally through the gap and straight into the left atrium. The bubbles bypass the lungs filter entirely and enter your arterial blood supply, rocketing straight toward your brain and spinal cord. Because this defect is silent on land, you cannot assume the hole has closed just because you feel healthy enough to go for a run. The only way to definitively prove the surgical puncture has healed is to undergo a bubble contrast echocardiogram before you ever consider getting back in the water. What happens at the microscopic level dictates your survival on the surface. Diving without absolute proof that the septum is fully closed means you are effectively playing Russian roulette with venous gas emboli. When we map all of these medical realities, the healing time, the physical metrics, the medications, and the structural integrity of the heart, we can clearly identify who gets to dive and under what conditions. This scorecard breaks down the 3 primary outcomes. First, the casual vacation diver. Their septum has fully closed. They can easily hit 13 mets, and they are off all major heart medications. This diver is generally cleared to return to the ocean, provided they stick to shallow, warm water, strictly no decompression profiles to minimize their total bubble load. Next is the hardcore tech diver, but their bubble echo reveals an open iASD. That open hole is an absolute deal breaker for deep decompression diving. To return to diving, they must scale back to conservative recreational limits, or undergo a second procedure to close the defect. Finally, we have the disqualified diver, burdened by persistent atrial fibrillation, poor exercise tolerance, or full-dose blood thinners. For this group, diving must be paused. The risk of passing out underwater or suffering a fatal hemorrhage from a boat injury is too high. Returning to the water after an ablation requires a total reset of your safety protocols. Success depends on treating your post-operative medical checklist with the same technical precision and respect as the dive plan itself.